Hi, this is Dr. Jennifer Dory with Procedure Ready OBGYN. Today we're going to be talking about some updates in family planning with a focus on contraception. The contents of today's talk, we're going to review overall contraception, including some updates on durations and indications. We're going to talk about a few new contraceptives, including Annovera, Slind, and Phexxi. We'll talk about some newer emergency contraceptive options and review the older emergency contraceptive options as well. And we'll do a brief update on mifepristone at the end. So just to talk about birth control options, when I think about birth control options and when I talk to patients about birth control options, there's a lot of options and there's a lot of things to consider about each option. This can lead to something in consumer behavior research known as choice overload. Giving people too much information about too many options can lead to people wanting to not make a selection at all, which for a lot of people who come in for contraception is sort of the worst choice you can make, just putting you at the higher risk for an unintended pregnancy, which patients who come in to talk about birth control, we're there to try and avoid. So when I talk about birth control, I prefer to use this chart. This is a chart created by bedsider.org, which is a nonprofit aimed at educating people about birth control. And they do something really important in this chart that I do also when I just verbally talk to patients about contraceptions, which is binning them by level of effectiveness. So you'll see the orange tier is the most effective tier, about less than 1 unintended pregnancy. If 100 women use these contraceptive devices each for a year, so 100 woman years, less than 1 unintended pregnancy would occur with these 4 methods. The green tier below it is a slightly higher risk of unintended pregnancy, 6 to 9 out of 100, depending on usage. And then the bottom tier is the not so well, and that's up to 25 unintended pregnancies in those 100 women using them each for a year. So thinking about these in terms of efficacy is sort of one of the most important selection criteria for most women, and this sort of helps them delineate within that level of effectiveness that they're comfortable with, which are the best options for them. So as we go through this chart, we're going to start with the first tier, the most effective forms of birth control. So the first one we're going to talk about is sterilization. This is only to be used when people are 100% certain that they are done having children forever. Some people will view this in their mind as reversible, but nowadays most of these procedures are in fact irreversible for women because we do total salpingectomy, so we take out their tubes entirely. So the only options usually for conception after sterilization is going to be IVF or in vitro fertilization. A brief aside about sterilization. For women, it's an outpatient surgery. You have to actually go to the operating room, be put to sleep. Can be done laparoscopically or within a few days postpartum when the uterus is still large and at the level of the umbilicus. The methods can vary, but most commonly now the standard of care is full salpingectomy, so removal of the tubes. This is being done because there are some precursor lesions to ovarian cancers that occur within the tube called stick lesions, STIC, serous tubal intraepithelial carcinomas, that can later lead on to ovarian cancer, which we know is one of the deadliest forms of cancer for women. So if they're done with their tubes, they're no longer going to use them, take them out, reduce that risk of any potential future cancers, rather than just obstructing them. Some of the older obstruction options include clips, rings, silicone rings or bands that you would put on the tubes, or fulguration, which is just burning with or without cutting as well. So women's sterilization greater than 99% effective. None of these methods require any type of follow-up to ensure obstruction. There was an older method that was a hysteroscopic option called eSure that did require a follow-up to ensure blockage of the tubes. That is no longer available. It's been pulled by the FDA for some safety concerns. So all of these methods that are still available do not require any follow-up for women. This is to contrast it to men's, which is an outpatient office procedure, just limited restrictions afterwards, like lifting restrictions for about a week. Most people can return to work very quickly, and they need to return at 3 months to ensure azospermia or no sperm in the ejaculate. If the azospermia is confirmed on 2 subsequent samples, then it is greater than 99% effective at preventing future pregnancies. The men's procedure is the more cost-effective of the 2 sterilization options. And sometimes as OBGYNs, it's not always at the forefront of our minds, but always something we should be talking about for couples who are certain that they are done having children. All right, now let's move into talking about LARCs, or the long-acting reversible contraceptions. You'll see 3 pictures just popped up here. The first one on the left is the Nexplanon. It used to be called the Implanon in former iterations. The one in the middle is a copper IUD, and the one on the right is a hormonal or a levonorgestrel IUD. We'll talk about each one in a little bit more detail here. So before we can place a LARC, we need to be reasonably certain that somebody is not pregnant. And CDC actually has a list of criteria for that. So this is what we should be checking with women every time that we are considering placing a LARC. So we need to know that they meet one of these following criteria, along with having no symptoms or signs of pregnancy. So it can be greater than, that sign is facing the wrong way. Less than or equal to 7 days since the start of their normal menses. So if it's less than or equal to 7 days since the start of their normal menses, you can be certain she's not pregnant yet. Has not had sexual intercourse since the start of her last menses. Has been correctly and consistently using a reliable form of contraception. So for me, this does not usually include things like withdrawal, but does include things like condoms, birth control pills, anything else. And is or within about 4 weeks postpartum, or is fully or nearly fully breastfeeding, which is greater than or equal to 85% of the feeds, and less than 6 months postpartum, and that is called lactational amenorrhea. All right, so let's talk about each of these individual LARCs. The implant is a small matchstick. We tell patients it's a matchstick shaped and sized rod that gets placed in the arm, a few centimeters below the bicipital groove, and just under the skin in that subcutaneous space. We want to be able to feel it through their skin to allow for easy and reliable removal. The biggest issues with the Nexplanon, well, the biggest pros is that it's easy. Once it's in, you're done. There's no maintenance. There's no going to pick up prescriptions. There's no compliance required for it at all. It is 99.9% effective in the studies. It is, in fact, the most effective form of hormonal birth control. 99.9, whereas the other IUDs were 99.8 or so. So it lasts 5+ years, but it's only FDA approved for 3 years. I don't foresee them ever going for longer FDA approval. They could, but there is efficacy data that shows they last for 5+ years and they're effective for that long. And there's no pelvic exam required. So often these are more popular among some of my younger patients who otherwise don't need pelvic exams or have a little bit more discomfort during pelvic exams. And so IUDs are a little bit more daunting. The biggest con or complaint I get about it is just the irregular bleeding. Other cons to mention usually is that it's an office procedure for insertion and removal. And in very rare cases, there can be issues surrounding removal. If the device is placed too deeply, or if there's migration issues, or if there's quite a bit of weight gain and there's sub-Q added between the skin and the device, it can be more difficult and actually require an OR procedure to remove. In terms of bleeding, about 6 out of 10 women in the first 3 months will have a favorable bleeding profile. About 4 out of 10 will not. Of those, about one third will change to a favorable bleeding pattern. And overall, about an additional 50 total percent of those 4 will change to a favorable bleeding pattern, but then some of the favorable bleeding patterns will cross over. So on average, I tell people about 1/3 of women will be unsatisfied with their bleeding pattern and may lead them to either use an additional form of contraception to regulate their menses, or can even lead them to removing the Nexplanon completely. But more than half of women are generally very happy with their bleeding pattern on the Nexplanon. Thinking about the duration, so prolonged use of the etonogestrel implant, which is their Nexplanon, and the levonorgestrel IUD, 2 years beyond their relative FDA approval durations. So this was a study done at St. Louis and Indiana University, looking at how long are these devices actually good for. So they found that the etonogestrel implant, so the Nexplanon, maintained their serum concentrations of etonogestrel at year 3, year 4, and at year 5. And this was them checking to see if it was different by BMI, as several of our hormonal contraceptive options we'll talk about later are sensitive to BMIs and are less effective in higher BMIs. The Nexplanon did not show any decreased efficacy or serum concentrations at higher BMIs and was effective for the full 5 years. So there were no pregnancies out of 291 implant users that used it for 5 years. And in fact, 102 or 35% of the participants kept the implant for more than 24 additional months, so greater than 2 years after that 3-year FDA approval period, and there were no pregnancies reported in that group. And there's case reports of lost Nexplanons causing persistent infertility for greater than 6 years after insertion. So Nexplanons really may be good for even longer than 5 years, but we don't yet have the data to state that. So I tell patients this is good for up to 5 years if they choose to keep it, but it's FDA approved for 3. So if their bleeding gets funny or if they just feel better having it replaced at 3, I'm happy to do so. But the efficacy data shows that if they would prefer to avoid another procedure and want to leave it for up to that 5, that is perfectly fine. All right, let's talk about the levonorgestrel IUDs. Several different types in this category. You've got your Liletta and the Mirena, which are in fact the same hormone, levonorgestrel, and the same dose, 52 micrograms. The biggest difference between these two IUDs is Mirena was the initial one. They patented the device. They got to run through their patent as the only player in the market for this dosage, and then they patented their inserting device so that they could maintain on patent and continue to charge more. Liletta then came around to have a different inserter, same basic IUD as the Mirena, as the sort of generic Mirena. The inserter has 2 additional essentially clicks that I have to do as the inserter, and that is really the biggest difference. Otherwise, I see no difference in my practice between the 2 of them. Then you have 2 lower dose levonorgestrel IUDs, the Kyleena and the Skyla. The Kyleena is 19.5 micrograms and is approved for 5 years. The Skyla is 13.5 and is only approved for 3 years. And so we'll talk a little bit more about the differences between each of these. So Liletta and Mirena, I'm going to bin them together because, like I said, the only real difference is the inserter. The big pros are it's easy, it's sort of set and forget, similar to the Nexplanon. Once it's in, you don't have to do anything about it. Greater than 99% effective, and it lasts 7+ years. So for people who are younger and they know they're going to want to wait a while before starting their families, or people who are thinking they're going to be done having kids, or just planned at least a couple years in between kids, it can be a very nice, potentially long-term option for them. About 20% of women will achieve amenorrhea within 2 years, and that number continues to go up a little bit each year after that. And it has limited systemic hormones. While some of the levonorgestrel does get into the bloodstream and move systemically, the majority of it stays right in the uterus where you want it to be, and causes the local effects that cause both its amenorrhea profile and the contraceptives profile. The big con with it is just insertional discomfort. So it's not super comfortable to have placed, particularly in a nulliparous or a vaginally nulliparous woman. But they can be well worth it because you can leave it for 7 years. So kind of talking about those pros and cons. The diameters are different in terms of the millimeters between all 4 of these levonorgestrel IUDs that we'll talk about. There's been a few studies that looked at, does this diameter correlate with difficulty of insertion, pain at insertion, and those things. And the few studies that have been done on this show that it doesn't correlate. So I won't go too much into the differences in the diameter and sizing, because if it doesn't make a difference clinically, it's probably not that important. And then the bigger things that we'll talk about for all IUDs, there's a risk of perforation or migration. So either when you're placing the IUD, that it can perforate through the myometrium completely, or that it can actually, a single arm could perforate into the myometrium. With contractions or cramping, and then there's a risk of expulsion and malposition. So either the uterus trying to expulse it, having it end up, sitting inside the cervix, or passing a big blood clot and passing the IUD with it. The Liletta and Mirena are both used also for bleeding issues, and so people who have sort of AUB or abnormal uterine bleeding at baseline are far more likely to have these issues with expulsion and malposition. There's also a relatively increased risk of ectopic pregnancy if you were to get pregnant. Overall, the absolute risk of ectopic is much lower if you have a IUD than if you don't, just because the risk of pregnancy is so much less with an IUD. But if you were to get pregnant with an IUD in place, it is a relatively higher risk that it will be ectopic, because the IUD is going to limit its chances of implanting within the uterus. All right, looking back at that same study that we talked about for the Nexplanon and the efficacy of the levonorgestrel IUD 2 years beyond FDA approval, the failure rates were 0.25 and 0.43 per 100 woman years at 6 and 7 years respectively. So these are very similar to the failure rates during the first 5 years. So their study concluded that it is effective, safe and effective for 7 years, possibly longer. So similar to the Nexplanon, I tell women this is FDA approved they're both FDA approved now for 6 years. and hopefully they will go for 7-year approval in the near future. But I tell them if they would like to leave it for 7 years, they are welcome to. As an OBGYN resident, I happily left mine for nearly 7 years once I read the studies, because I said, hey, if I don't need another insertion, all the better. The two other types of IUDs, Skyla and Kylena. Skyla was the original low-dose levonorgestrel IUD on the market. It was approved for 3 years. They were marketing this towards nulliparous women, people with smaller cervices, because of the smaller insertional diameter. Like I said, the studies don't show that that really makes a huge difference, so I don't usually tell people, nulliparous women, that they should be thinking more about one of these smaller ones necessarily. The Kylena has now kind of come in and taken over quite a bit of their market share because it's a similar dose, 19.5 as opposed to 13.5, but it's actually FDA approved for 5 years. So people, if they are planning a little bit more spacing in terms of their family planning, gives them more options and fewer visits to the doctor. Also, 5 years can be a pretty nice routine for women to get into because it often lines up with their pap smears after 30, when if they have normals, they're at Q5 years for their co-testing. These both have lower rates of amenorrhea, and for people who want to have a period because it makes them feel better in terms of knowing they're not pregnant, that can be a nice option for them to both have the benefits of a lighter period, but still knowing that they're getting a monthly cycle. All right. The last one in the LARC category is the copper IUD. And the copper IUD has copper along the shaft and 2 little bands along the arms of the IUD. This is sort of the positioning of it, or of any of the IUDs within the uterine cavity. Again, the pros are similar to the other ones, to the other IUDs, easy, greater than 99% effective, but these last 12 plus years. FDA approved for 10 years, but we know they last 12 plus years. And this one has no hormones. So for women who are particularly concerned about any hormones, or people who have a history of breast cancer or anything for which they are absolutely not candidates for any type of even low dose hormones, this can be a nice, very effective form of reversible birth control. The cons, the same things as the other IUDs, but this one also adds heavier menses. So unlike the hormonal IUDs that make your menses lighter or go away, this can make your menses either heavier or longer in duration. All right, overall IUD contraindications. This is from a source called the CDC MEC, or the medical eligibility criteria, and you can find the medical eligibility criteria for all types of birth control there. Severe distortion of the uterine cavity. This can include things like fibroids, or a bicornuate uterus, or a severe arcuate uterus, so anything that distorts that cavity. Active PID, so any active infection generally, less than 3 months since endometritis. So if somebody had endometritis peripartum and then comes in at their 6-week visit, we should technically be waiting until about 3 months to place that postpartum. A current pregnancy, obviously, if we know somebody's pregnant, well, that's why we went over first that reasonably certain criteria, so we can be reasonably certain they are not pregnant. Active breast cancer or a history of breast cancer is a relative contraindication depending on the hormone receptor status of the breast cancer, and that data and recommendations are evolving all the time, so just keep checking back in on that. And suspected uterine malignancy is on this list. However, levonorgestrel IUDs are considered the standard of care for anybody who is not a surgical candidate for uterine malignancy. If you're placing it once you actually know that you have a uterine malignancy, simply because they're not a candidate for surgery, that's reasonable. But if you have only suspected, and you need to prove one way or the other so you know what you're treating. Pelvic TB, Wilson's disease is a contraindication for copper IUD, and then abnormal bleeding is a relative contraindication for copper IUD, just because the copper can make the abnormal bleeding worse. All right, so now we're jumping down to this green tier. They work pretty well, not as well as that top tier, but pretty darn well. And we'll go through each of these. So four big categories in here: pill, patch, ring, and shot. First, we're going to talk about combined hormonal contraception. So the ones that are combined are the ones that have estrogen and progesterone. And these have their own very specific absolute and relative contraindications that you can see here. The biggest ones during your clerkship are going to be migraines with aura. They love to ask about any history of VTE or PE. And then hypertension are often the biggest ones that we talk about in young, otherwise healthy women. You should know all of them on this list. Those ones, and then the relative contraindication that you'll see pop up on your test is greater than 35 years old and a smoker. All right, this is just a little graph to show you what the serum concentrations look like for the 3 different types of combined hormonal contraception. So the green line with the circles is your oral contraception. So you see this big peak a few hours after you take your first dose, your dose in the morning or in the afternoon, whenever you do, a few hours after you take your dose, and then you go through your first pass metabolism that comes way back down, and then you have this big trough right before you take your next dose the next day. So there's a lot of hormonal shifting with the pills particularly, and this is just something to be aware of, particularly in women who tell you that they felt very sensitive to those swings and those shifts on oral contraceptives. Doesn't mean that the other types of combined hormonal contraceptions won't work for them, because as you see, all the other two types, the patch and the ring, have much more consistent lines. The vaginal ring is really the lowest dose of systemic hormones, because it's very slowly and very consistently absorbed, so you don't require such a high dose. The patch is sort of that middle of the road red line there. We'll talk about each one in detail. So the pill. This is probably the thing most people are the most familiar with, most patients when they come in. They know somebody who's been on the pill. They've been recommended the pill by somebody. They want to talk about the pill for most people. So the biggest things about the pill, you got to take it at the same exact time every day. You got to kind of be a robot about it, which depending on your life, it may or may not be feasible. Somebody with a life like me, I take random, 24-hour calls. Very hard to do the same thing at the same time every single day when sometimes I'm awake at 2 a.m. and sometimes I'm not. That being said, just talking to people about the expectations and then what to do about missing a pill and what that risk is to them. And like everything in life, most decisions in medicine are all about your risk tolerance, both yours as the provider's and the patient's own risk tolerance. And if you have that conversation and the pill's the best fit, great. So when you're thinking about then you're as the provider picking the pill for them, I tell them outright, there are hundreds of types of pills. There are brand names, there are generics, there are different estrogen doses, there are different progestin types, and there are different progestin doses. So that being said, I can't pick the right one for everybody on the first try, but I tell people about all the different options so that they know if what I pick isn't the right one for them, it doesn't settle with them, they're having side effects. I want them to tell me. I want to be able to say, okay, that wasn't the right one based on the side effects you're telling me or the symptoms you're telling me. I think this will be the next best one to try, and we can switch it around and play. But I think if you don't set the expectation that there are different options and different ones that'll settle better with your body than others, then people will take one pill once and think that all pills are not going to work for them. When in reality, for many women, this is a great form of contraception, and we can find one that works well with their body. So for a otherwise healthy woman who comes in to see me and just wants a pill for birth control for no other reason, she's not having heavy menses, she's not having a lot of dysmenorrhea, she's not having hirsutism or PCOS symptoms or anything else, I often say I err on the side of starting in the middle. I want to kind of average the risks and the benefits on either side of both the estrogen and the progestin. And so my take on it is I usually start in the middle with about a 20 microgram pill. I find a lot more women at 30 and 35 tend to have more issues with headaches and other things. But that being said, if somebody has PCOS or has AUB, I'm going to start at those higher doses because they often need those higher doses. But like I said, for somebody with no other symptoms, I'll start around in the middle, around 20 micrograms. And then I start in the middle of androgenicity for the progestin. And so I go with a sort of middle of the road North syndrome, which takes me to Junel FE being one of my sort of go-to starter packs of pills for people. And this is for somebody who's not been on pills before, doesn't know have something that's worked for them. But this tends to be where I start for, like I said, somebody without any other symptoms. If somebody has PCOS, if somebody has hirsutism, if somebody has AUB, I start with a higher dose, a 30 or a 35 microgram pill, and also try to tailor the progestin content to whatever symptoms they might be having. But have a few that you sort of start with baseline and then just sort of make sure you're comfortable going back and making adjustments for people. If you're having more headaches, more issues with that you think are related to estrogen, more GI upset, then you might want to come down on your estrogen. If you're having more breakthrough bleeding, more heavier bleeding, and more hirsutism, you might want to go up on your estrogen content or pick a more anti-androgen for your progestin. And sort of just make those adjustments from there, but give patients realistic expectations from the start that you may need to, try a couple before you find one that fits. It's like trying on clothes or anything else. It can take a little while to find one that really works for you, but once you find it, that's great, and you can often stick with it for quite some time. All right. Couple other ones. The patch can be nice for a lot of women. It's a small little adherent sticker like that. Looks very similar to the nicotine patch, but most women tend to wear it under the bikini line in the front or in the back. And rotate the location each week. Transdermal absorption, continuous throughout the day, leads to more of a faster steady state rather than the peaks and troughs that you saw with the oral combined contraceptive. You change out the sticker weekly, and it's possibly less effective with a BMI greater than or equal to 30. In some of the original studies, those women were not included. There's been some studies looking at elevated BMIs that just show potentially less effective, but the fecundity or the pregnancy rates at baseline are lower in women with a BMI greater than 30. And so in several of the studies looking at the efficacy of the patch with a BMI greater than 30, it found the same types of failure rates, relatively equal failure rates between all BMI groups, possibly because the lower efficacy is balanced by the lower fecundity. So they're less likely to get pregnant at baseline. And so even if the patch is 90% effective instead of 94% effective, they're still getting pregnant, having failures roughly as often as those with a BMI less than 30. So greater than 30 is not an absolute contraindication to me. It just requires informed consent from the patient. The biggest complaint I get with this is skin irritation. If you're someone who has sensitive skin, you tend to get itchy or irritated with Band-Aids or other adhesives on your skin, probably not right for you. People who do a lot of water sports, it can still work very well. In Hawaii, I had a couple of people who were avid surfers and things. If they were strategic about where they placed them, sort of under the bikini line and things, for the most part, they very rarely had them fall off. I've more often had people with young children have their kids accidentally take them off with their little fingernails than I have had issues with like water sweating, those sorts of things. All right. The final combined type is the ring, and there's now 2 types of vaginal rings. For a long time, NuvaRing was the only game in town for vaginal rings, and now we have another one called Anovera, or the yearly ring, which is great. Both of them about 93% effective. The picture on the left here is where the NuvaRing tends to sit, higher, typically up around the cervix. It's a little bit bigger in diameter. The opening of the circle is bigger in diameter, and the actual diameter of the ring itself is thinner. Whereas the Anovera is a thicker ring with a smaller opening in the middle. And so it does tend to sit a little bit lower in the vagina, like the picture on the right there. So the NuvaRing, here's a size reference for you. It's clear to opaque. You pinch it in the middle or twist it in the middle, and then can insert it very similar to inserting a tampon with or without an inserter. Some people also use a tampon inserter to insert it. The biggest things, you leave it in for 3 weeks, you take it out for the 4th week to have your withdrawal bleed, or some people choose to leave it in for the full 4 weeks so they just have spotting rather than a full period, and then replace it after 4 weeks. Biggest complaints are that you can feel it during exercise or sex, and then difficulty inserting and removing. For some people, if they or their partners feel it during sex, they can take it out for sex and put it back, rinse it off, put it back in afterwards. As long as it's out for less than 24 hours, it's not a problem for the NuvaRing, and that's a big difference between this and the Anovera, so we'll talk about that. The Anovera, you can see this relative size there, a little bit thicker in terms of the ring itself. You remove it every 4th week. You leave it out for a week, put it back in so it stays in 3 weeks, out for the 4th week, and you just repeat that. There's limited data on the continuous impact on the total duration you can use it. So if you use it like that, where you're removing it every 4th week for a week, it's good for 13 cycles, but it has a limited amount of hormone on it. So if people choose to leave it continuously, it likely does not last for that same 13 cycles, probably a little bit less because you're absorbing hormone that whole time rather than just 3 out of every 4 weeks. This is relatively new to the market, and so I wasn't able to find any studies yet that looked at continuous use impact on the total duration. And this one has a less robust window for forgetting. So if you leave this out greater than 2 hours total in 21 days, you need to use a backup method for the remainder of that cycle because you can escape ovulate. And so 2 hours is not a very long time, particularly if you take it out for sex and fall asleep afterwards. It would be easy, even just one episode. Or if you take it out for sex routinely and always remember to put it back in, but a half an hour here and there, it's quick. It's easy to add up to 2 hours over those 21 days. And so I think is going to be a little bit more problematic for people who do have issues with feeling it during sex and exercise. Same sort of issues in terms of the complaints, feeling it during sex and exercise, a little bit more commonly with the Anovera than the NuvaRing, I think just because of the size difference. And then again, you just have to be comfortable inserting and removing it. The last one on here is the shot. This is Depo-Provera. This is an injection every 12 to 15 weeks. It's just a single large dose of progestin. And so the complaints, you can have some irregular bleeding for most people after that first, like when they actually get after their second shot, when they're on their second cycle of it, they tend to not bleed again until you're just about due for the shot. So you typically have 3 months without bleeding, get potentially one period, and then get your next shot. Some people have no bleeding at all in between their shots if they come on the early side, like closer to every 12 weeks rather than every 13, 14 weeks. There is some associated weight gain. When you break down the studies that look at weight gain, teenagers and those who are still actively growing are the most susceptible to this. Depo-Provera in large doses can actually increase one of your hunger hormones. And so people who are more sensitive to their hunger hormones when they're still growing are more susceptible to the weight gain issue. But people tend to fall in one of two camps. It's either you gain weight with it or you don't. And so for a lot of people, I just say, if you want, we can try it for a 3-month period. And most women know pretty quickly if they're going to be in that gain weight camp or not. And then you can stop if you are in that camp and you don't like it. There's a delayed return to fertility with it. Some people, depending on how long they're on it, can take several months to a year to return to normal ovulation. And then there's some issues around bone density loss. The bone density loss issues plateaued around 2 years of use of Depo and don't tend to get worse beyond 2 years. And then they rebound and you return to fairly normal bone density quickly after stopping your Depo-Provera. But because of that bone density loss and the need for estrogen to rebound that bone density, I don't like to use Depo-Provera as you approach menopause or through menopause because it doesn't give you that chance to do your catch up in your bone density right before you're at your highest risk for osteoporosis. All right, and then we're going to talk about one of the other newer ones, Slind, which is a pill. So we're coming back around. So we've gone through the pill, the patch, and the ring as combined hormonal contraception. All of which had estrogen and progesterone. And now there's a couple pills that just have progestin. So there's a standard Progestin-only pill that's norethindrone, which has been around a while that we're not going to talk about. Particularly, it has a much higher failure rate, and you have to be super careful about what time of day you're taking it. Slind is the new one. So Slind is drospirenone rather than norethindrone, and it's 4 milligrams as opposed to the typical Progestin-only pill, which is 0.35 milligrams of norethindrone. So this is a much larger dose of progestin. But as a result, it's a much more robust effect. You can have a 24-hour missed pill window with this, as opposed to the progestin pill, which you have about a 1-hour window. So it helps a lot with the overall efficacy of this because there's a larger window in terms of forgetting. So 92 to 96% efficacy in the studies, and it didn't have any BMI limitations on it, unlike some of the other hormonal options. So it is an estrogen-free option that is just a lot more effective than the typical progestin-only pill, which is quite nice. The main side effects are some concerns about acne, nausea, vomiting. Hyperkalemia is the bigger one. Because it is drospirenone, which has sort of a spironolactone analog effect, and so it can cause some hyperkalemia. So anybody who has like kidney disease or is at risk for hyperkalemia, you should just be checking some labs after you start this, just before and then after, just to make sure you're staying in an okay place. But in the studies, most people who did have a transient hyperkalemia self-regulated themselves back to a normal place, unless they had severe kidney disease or something else. And then there's also a risk about drospirenone was the progestin in the Yaz and Yasmin combined hormonal contraceptive pills that was associated with an increased risk of VTE compared to other combined hormonal contraceptive pills. And the thought was that the drospirenone was more prothrombotic than some of the other progestins we have. So there is some theoretical risks about VTE. In the FDA submitted studies so far on this, that has not been borne out. There were no VTEs in those studies. But again, this is new to the market. We will see over the next couple years. So in my head, I would just informed consent, mention it to patients. If they don't have any significant risk, it's still so much lower risk than a VTE than pregnancy, number one. And number two, any other combined hormonal contraceptive. And so I would still prefer this over anything with estrogen, and certainly prefer it over pregnancy. Because one of the things with birth control, you're comparing these things often to pregnancy, not to nothing, in sexually active reproductive age women. All right. And then there's one new one that joins this lower tier. We're not going to go through the withdrawal, the fertility awareness, internal condoms, and male condoms, but we are going to talk about one newcomer to this space, which is going to be a spermicide condom combo called Phexxi that you've probably been seeing in the news or having patients ask you about. So Phexxi is a lactic acid, citric acid, and potassium vaginal gel. It was originally marketed as a lubricant, but it has a very acidic pH, which immobilizes sperm. So the overall efficacy is about 86%, and that's including women who use this in conjunction with condoms. Perfect use was about 93% effective, but actual use is about 72%. And the reason being, it's a little bit cumbersome. You apply an applicator tube to the vagina within 1 hour of penetrative vaginal sex. And you have to apply a new applicator for every sexual act. And so if more than an hour elapses between when you inserted the Phexxi and when you're going to be exposed to semen potentially, you have to stop and apply a new applicator as well. This is then compounded by the fact that about 1 in 5 women will have significant vaginal burning from that acidic pH. About 1 in 10, a little more than 1 in 10 will have vaginal itching. About 6% have reporting more UTIs. And then I think the ultimate unintended consequence of a less than ideally effective birth control is pregnancy. And I don't know who out there is setting a timer when they are doing birth control and having sex, but I think it would be very hard to always be cognizant of that 1 hour mark and reapplying. And it's honestly not cheap either. So condoms are more effective for most people who've been asking about it. I'd say I recommend using it in conjunction with condoms, in which case I don't know that it adds a whole lot to condoms unless you just want to have something as a backup in case a condom were to fail you. But I would certainly recommend condoms over this at this point in time. All right, let's talk about emergency contraception. This is, again, by the same group, bedsider.org. This was their original chart on emergency contraception, the copper, IUD, Ella, and Plan B. And there's a new addition to this chart, which we'll talk about in a moment. So the original types of emergency contraception, there was a method you could take by taking several regular birth control, combined hormonal birth control pills, called that's this top one here. There's Plan B, which is a levonorgestrel only, 1.5 milligrams, or 0.75 times 2. And ulipristal acetate, or Ella, that came out within the last 10 years. And then the copper IUD, which is been around for a little while as emergency contraception, and more recently, the levonorgestrel IUD, the 52 microgram levonorgestrel IUD, has now been approved, or the studies have been shown that it works for emergency contraception as well, and so I'm now offering that to patients for emergency contraception. So talking first about Plan B, the biggest things to know about Plan B, it's the sooner you take it, the better. You need to take it as soon as you possibly can after sex. It inhibits your LH surge. It will prevent at least 50% of expected pregnancies. And it works better if it's taken 2 days prior to your LH surge. So if you unfortunately had sex on the day you were surging, it's probably not going to work for you. And it's not effective. It's not very effective in BMIs greater than 30. So if your BMI is greater than 30, we should be looking at something else for you. And then the side effects for these are they're going to be pretty similar: nausea, vomiting, and abnormal bleeding. Ella, ulipristal acetate, is going to be a selective progestin receptor modulator, 130 milligram tablet. This is prescription only, whereas Plan B, I forgot to mention, is now over the counter in most states. Ella can be used up to 5 days after intercourse, and is equally effective on days 1 and day 5, which is nice. So you don't have to rush out and find a pharmacy that's open on a Sunday. You can wait till Monday and it's perfectly fine. But this one has limited efficacy with your BMIs greater than 35. So still, this leaves a lot of our patients for whom Plan B and Ella are not good options. So what else can we offer to these women? Well, first, ulipristal acetate. The other big thing to know about Ella, if you're going to prescribe it, is that it can impact some of your other forms of contraception. So unfortunately, it can prevent a pregnancy only to make your other contraceptive fail, and or to have your other contraceptive inactivate your Ella and have a failure occur. So you have to delay combined hormonal contraception. You have to delay the Nexplanon as well, and Depo. You can do any of the IUDs concurrently with this, and you're fine there. Side effects are going to be headaches, nausea, vomiting. All right. And so what can we do for BMIs greater than 50 or greater than 30 or 35? Newer article that came out in JAMA looking at the levonorgestrel and copper IUDs for emergency contraception. In this study, 317 women received the levonorgestrel IUD and about 321 received the copper IUD. One woman in the levonorgestrel IUD did get pregnant after insertion, and 0 in the copper IUD. So this was a non-inferiority trial. So they were simply trying to prove that the levonorgestrel IUD was not inferior to the copper IUD. And despite the fact that they had one participant in the levonorgestrel IUD, that was not statistically significant in terms of the difference between that and 0. And so it was proved to be non-inferior. So levonorgestrel IUD was non-inferior to the copper IUD for emergency contraception. So the copper or the levonorgestrel IUD can be placed up to 5 days after unprotected sex with equivalent efficacy and a higher continuation rates than other birth control when birth control is initiated at a emergency contraception visit. And there's no BMI limitations. So this can be nice not only for emergency contraception in the moment, but for ongoing contraception. So here you'll just see I added the levonorgestrel IUD to the chart to sort of complete it and keep in mind that those are both options. All right, we're going to talk very briefly about some mifepristone and some updates in the usage of that within the family planning world, but also in terms of routine OB. So mifepristone has been undergoing several changes in terms of the regulations surrounding it in the last 5-10 years. So the FDA has had a lot of requirements and restrictions along mifepristone, and it's called REMS criteria and the risk evaluation and mitigation strategies. So they updated them during COVID and got rid of a really big thing, which was the in-person dispensing requirement. So we used to have to bring everybody in who needed mifepristone into the office. I would have to hand them the pill in a cup of water and physically watch them take their mifepristone. I no longer have to do that, which is great. So now they need a visit with a certified healthcare professional, but this can be telemedicine. They need to counsel and they need to sign a patient agreement form, which can be done electronically. And they need to get the mifepristone from a certified pharmacy that is certified to dispense mifepristone. But all of this can be done remotely for people in rural communities, for people with transportation issues, or for people who simply can't make it into the clinic. It can be a very nice increased access option. And it's particularly salient because now we're using mifepristone not just for elective terminations, which is sort of the thing people know it most commonly for, but for mifepristone pretreatment for medical management of early pregnancy loss. So for people with missed abortions in their first trimester, mifepristone can be used to pretreat before your misoprostol to increase the efficacy of medical management. So looking at this chart, you'll see the success rate in the pre-medicated group was much higher, 83% versus 67% in the misoprostol alone. So it increased your chance 1.25 times. You're 1.25 times as likely to be successful if you took the mifepristone than if you just took the misoprostol, which is a big deal when you realize that a lot of those failure rates are going to require a procedure to complete the process. And the procedures are not only time-wise cumbersome, but can be quite expensive depending on your insurance, unfortunately. And especially for something that's potentially was a desired pregnancy, it's just adding insult to injury to then have to, have a big out-of-pocket expense and waste, a few days coming in and dealing with this. So whatever we can do for people who do choose medical management to try and increase their success rates at home, all the better. Another study that looked at this pre-medication, randomized double-blind placebo-controlled trial. This looked at the failure rate. So this is looking at the failure rate. So the failure rate in the mifepristone group was 17%, and in the placebo group was 24%. So it decreased that failure rate pretty effectively. So for missed abortion, it's now becoming the standard of care for women who choose medical management to get pre-treated with the mifepristone, 200 milligrams, 24 to 48 hours prior to their 800 micrograms of misoprostol. And so women come into the office, they get counseled, expectant management option, medical management option, procedure option, and procedures being, depending on your location, what you got, either office management or operating room management. But those who choose medical should be given the option of mifepristone. It can still be for some women prohibitively expensive if it's not covered by insurance. And so I certainly don't require it. If misoprostol is super cheap for most insurance plans, and just out of pocket. So if people can only afford to do the misoprostol, there's nothing wrong with that. But for women who really want to optimize the efficacy of medical management, adding the mifepristone can be a nice option. We need to increase the access to Miffy. We're still working on that in a lot of places, but I think these decreasing REMS requirements are doing a lot of good to try and help us do that. But we still have some hoops to jump through in terms of finding certified pharmacies and all those things, and then the cost portion of it. It can also be added to a second trimester induction of labor termination, either for a missed abortion in the second trimester or for a termination, an induction termination. You can give Miffy 12 to 48 hours prior to the induction, and for that induction be using either misoprostol or Pitocin induction, and it's shown to be increasingly effective for either type of induction. All right, quick recap. Birth control duration, Nexplanon, good up to 5 years. So counsel your patients on that. Levonorgestrel, 52 microgram levonorgestrel IUDs, good up to 7 years. The new birth control ring, new birth control options, the Annovera yearly ring, take it out monthly for your menses. If you don't, I don't know what to tell you in terms of duration. I would say subtract all those weeks you've taken it out from the total efficacy and err on the side of getting a new one much sooner. Phexxi, pH modulating gel, large difference in the perfect use and actual use efficacy. So don't be confused by those two numbers. And I think it needs really good counseling to go along with it. Emergency contraception, make sure you're offering that levonorgestrel IUD now. And making sure patients know about the BMI limitations of the oral emergency contraception options when you're talking about those. And the mifepristone, the FDA reducing barriers is helping us increase our access points, but we still need to be doing what we can to help make sure patients are aware of these newer things. Some resources, bedsider.org. One of my favorite resources, both for providers and patients. Really great interactive website for patients, but also has very good information for providers when you want to review stuff. CDC-MEC/SPR. There's an app you can download on your phones. It's free. Walks you through all those medical eligibility criteria for all your different birth control options. Planned Parenthood website. Now they have really upped their game in the last 5 years, and really good interactive stuff for patients. Very you can make it personalized, and there's just a lot of good stuff on the Planned Parenthood website now. They now teamed up with somebody else. They made this Planned Parenthood spot on period and birth control tracker, which is great. So for people who are using the pill, the patch, the ring, something like that, that has a higher failure rate due to human error, you can track your periods and then put in, I forgot to take my pill on this day. What do I need to do about it? I left out my ring on this day. Do I need to do anything about it? And it'll tell patients if they need to use a backup form of birth control or sort of what their risks of escape ovulating and thus pregnancy might be. So really nice resources for patients and to be able to point your patients towards. This is what the CDC MEC app looks like. You can go through, you can either search by the type of contraception and look at the contraindications, or you can look by the condition. So you can look up Crohn's disease, and you can look at what your patient has. You have a patient who comes in with Crohn's disease, you can look up what the recommendations are for different contraception options with Crohn's disease. They also make charts that you can keep in your office. This is what it looks like. One means there are no restrictions for that condition and that type of birth control. Two, which is the lighter green here, shows that the advantages generally outweigh the risks. The pink 3 is theoretical or proven risks that usually outweigh the advantages, but there's still some room for sort of, I think, patient joint decision making and informed consent there, depending on the clinical scenario. And then red, the deep red 4 is essentially, that's a no-go. That is an unacceptable health risk between that condition and that type of contraception. So always good to just double check. They do update these occasionally. I haven't seen this one updated in a little while, but they do update them occasionally as new information becomes available. And that is all I got. So if you guys have questions, feel free to shoot me an email or write in the comments, and I'd be happy to either add stuff in here or just write back to you if you have any specific questions about anything. Hope that was helpful. And again, this has been Dr. Jennifer Dory with Procedure Ready.